Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 347 of our pharmacotherapy series, which majors in dosing of drugs in renal failure. After 72 hours of gentamicin therapy, G.G.K's peak and trough levels are 7.6 and 2.6 mg per liter, respectively. Her physician attributes this to a gradual decline in renal function. Her most recent serum creatinine is 4.8 mg per deciliter. So my question to you is, how would you revise G.G.K's dosing regimen based on these levels? A gentamicin trough level of more than 2 mg per liter suggests that G.G.K's dosing interval is too short. Although her peak concentration is within the normal range of 5 to 8 mg per liter, her trough concentration indicates that she is at a potentially toxic level. Her pharmacokinetic parameters can be revised based on these values, and a new KD can be estimated from the relevant equation, which yields a value of 0.047 per hour. Because little change in G.G.K's volume of distribution for gentamicin is expected, a new clearance for gentamicin, abbreviated as CL revised, can be estimated from her revised elimination constant. If necessary, a revised VD gent could be calculated, keeping CL gent constant, although the clearance is more likely to change than the volume of distribution. Inserting the correct values in the relevant formula yields a CL revised value of 0.82 per hour. These revised values for KD and clearance can now be used to calculate a revised maintenance dose to maintain the trough concentration at less than 2 mg per liter using an earlier equation. This yields a dose of 115 mg, which can be rounded down to 110 mg every 48 hours. My next question to you reads, what are some limitations in calculating G.G.K's creatinine clearance based on her serum creatinine? Can this estimate safely be used to predict gentamicin clearance? For patients with stable renal function, creatinine clearance can be estimated from serum creatinine using the Cockcroft-Gault equation. In a patient such as G.G.K, however, whose renal function continues to decline during the hospital course, estimation of renal function based on her increasing serum creatinine becomes more difficult. Because her serum creatinine does not reflect a steady state level, the previous equations can no longer be used to accurately estimate her renal function. Because G.G.K's serum creatinine has increased rapidly from 3.4 to 4.8 mg per deciliter during the past few days, her creatinine clearance is probably much lower than that estimated using the Cockcroft-Gault method. A rising serum creatinine may represent a decline in renal function manifesting as an accumulation of creatinine. Although prediction equations such as the modification of diet in renal disease, abbreviated as MDRD, equations are a good measure of glomerular filtration rate, they were developed in patients with chronic kidney disease, therefore limiting its use in healthy patients. In addition, the modification of diet in renal disease equation has not been validated for the dosing of most drugs in the setting of renal dysfunction. There can be significant differences in drug dosing regimens when the modification of diet in renal disease and Cockcroft-Gault methods are used to estimate renal function. In 1998, the FDA recommended using the Cockcroft-Gault equation to estimate kidney function when designing pharmacokinetic clinical trials and drug dosing regimens. The Cockcroft-Gault equation has been the standard method to estimate renal function to determine if drug dosage adjustments are necessary. In 2010, the FDA released a draft guidance that included both the Cockcroft-Gault and modification of diet in renal disease equations to determine renal function. It also should be noted that the units for the Cockcroft-Gault equation for creatinine clearance is milliliter per minute, while the units for the modification of diet in renal disease equation for estimated glomerular filtration rate is milliliter per minute per 1.73 meters squared. The manufacturer's prescribing information and available literature should be evaluated to determine the appropriate dosage regimen based on the patient's renal function. G.G.K's renal function continues to deteriorate to the extent that she requires hemodialysis. What additional alterations in her gentamicin dosing regimen are necessary when she is having dialysis? Gentamicin has a molecular weight of about 500 and a relatively low volume of distribution, averaging 0.25 liters per kilogram, and is about 10% bound to proteins, all favoring effective removal by conventional hemodialysis. For a given patient, the observed dialysis clearance of gentamicin using conventional methods also depends on factors such as the physical properties of the dialysis filter, the blood and dialysate flow rates, and the length of dialysis. Studies indicate that dialysis clearance of gentamicin averages 45 ml per minute compared with an average plasma clearance of 5 ml per minute in patients with end-stage renal disease. Therefore, G.G.K's gentamicin dose must be adjusted to compensate for the amount of drug that will be removed by dialysis. Because drug removal represents a combination of drug elimination by the body and dialysis, the following equation can be used. CL total is equal to CL dial plus CL, where CL total is the total clearance of the drug during dialysis, CL dial is the clearance by dialysis, and CL is plasma clearance. If dialysis clearance is high relative to plasma clearance, drug removal will be enhanced by the dialysis procedure. The total clearance of gentamicin in a patient with severe renal dysfunction during dialysis is 50 ml per minute, that is 45 ml per minute plus 5 ml per minute, or 10 times the clearance while off dialysis. Appropriate formulae can be used to estimate relevant values. The fraction of gentamicin removed, F.D., during a 4-hour conventional dialysis procedure is approximately 50%. If specific data are not available for dialysis and plasma clearance, the following equation will predict fraction removed using the elimination half-life data alone obtained during dialysis. The estimated value of 50% removal is consistent with literature values indicating that 50% to 70% of a dose of gentamicin is removed during a 4-hour dialysis procedure. A limitation of this equation, however, is that it does not consider the redistribution of drug from the tissues back into the plasma after the dialysis procedure. It generally is difficult to calculate an appropriate maintenance dose for patients having hemodialysis that will maintain peak and trough concentrations similar to patients with normal renal function, in part because of the large variability found in aminoglycoside pharmacokinetic parameters. Sustained plasma concentrations greater than 2 mg per liter can increase the risk of toxicity. However, dosing gentamicin to achieve trough concentrations of less than 2 mg per liter may lead to prolonged periods of subtherapeutic peak concentrations because one would have to use smaller doses with lower peak concentrations to allow the troughs to decrease before the next dose. Another practical consideration is that unless one expects the patient to recover renal function in the future, renal toxicity of the drug is less of a concern. As a compromise in patients receiving hemodialysis, gentamicin doses are given to achieve a pre-dialysis trough concentration of approximately 3 mg per liter. This can generally be achieved with a loading dose of 2 mg per kilogram, followed by a maintenance dose of 1 mg per kilogram after each dialysis session. My next question to you reads, why does the dose of ceftazidime in G.G.K have to be adjusted because of her hemodialysis when this drug has such a large therapeutic window? Because only 21% of ceftazidime is protein-bound and its volume of distribution is 0.2 liters per kilogram, it should be readily removed by hemodialysis. The mean dialysis clearance of ceftazidime is 55 ml per minute, with 55% of the drug removed during 4 hours of conventional hemodialysis. A supplemental dose of ceftazidime should be given to G.G.K after each hemodialysis session to maintain a therapeutic concentration. Half of the daily ceftazidime dose should be administered after each dialysis session. G.G.K's physician is considering changing her from a conventional dialysis system to a high-flux system that uses high-efficiency polysulfone membranes. So my question to you is, how does the dialysability of gentamicin and ceftazidime differ with high-flux hemodialysis compared with conventional hemodialysis? High-flux hemodialysis is more effective than conventional dialysis at removing certain pharmacologic agents because the membranes are more efficient and the blood flow through the dialyzer is increased. Although limited data are available, a greater fraction of drugs, such as aminoglycosides, ceftazidime, and vancomycin, are removed by high-flux versus conventional hemodialysis. Approximately 50% to 70% of gentamicin is removed during a 2.5-hour, high-flux dialysis session. The clearance of ceftazidime by high-flux dialysis is 75 to 240 ml per minute compared with 55 ml per minute for conventional hemodialysis. Thus, further dosage adjustments for gentamicin and ceftazidime may be necessary if G.G.K is converted from conventional hemodialysis to high-flux hemodialysis. The next question reads, what changes would be necessary in G.G.K's gentamicin dosing if she were to start a CRRT such as CVVH? Because of the continuous nature of CVVH, the extent of drug eliminated by CRRTs will differ from intermittent modes such as hemodialysis. The clearance of a drug in a patient receiving CVVH can be described in a fashion similar to an earlier equation, where CL-dial is replaced with CL-CVVH. In G.G.K, the CL revised from an earlier equation can be used for the plasma clearance, abbreviated as CL. The clearance by CVVH can be described by the following equation: CVVH is equal to FU multiplied by UFR, where FU is the fraction of drug unbound and UFR is the ultrafiltration rate. Gentamicin exhibits low plasma protein binding, that is FU equal to 0.95. Typical ultrafiltration rates for CVVH are approximately 1 liter per hour, but can vary. Because the clearance of gentamicin approximates that of creatinine clearance, G.G.K's total clearance is approximately 1/3 the normal clearance of 100 ml per minute. Therefore, the gentamicin dose should be approximately 1/3 of the normal dose. G.G.K should be given 1.5 mg per kilogram per day or 100 mg of gentamicin as a single daily dose. Normal dose is approximately 5 mg per kilogram per day. Gentamicin trough concentrations should be monitored, and her dose adjusted to maintain a trough concentration of less than 2 mg per liter. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 348.